Anyway, good morning, everyone, and welcome to this LGBTQ+ History Month webinar. My name is Luke Heslop, and I'm the service lead for the Public Health Evidence team. And I'm joined here today by two members of my team. And if all goes to plan, Amy and Torero she'll be presenting the findings from our deep dive programme in relation to citizens identifying as LGBTQ+. And we also have Dawn, who shall be monitoring the chat throughout. As stated, we're recording this session, and it will be made available to view alongside the collection of other webinars that the Public Health team are producing for this LGBTQ+ History Month. Throughout the session, please turn your cameras and particularly your microphones off, but feel free to use the chat throughout, which Dawn shall be monitoring. And there shall be an opportunity to discuss the chat and ask any questions at the end. And most importantly, we want all our events, workshops and webinars to be safe places for everyone to learn, to share and to grow. Therefore, we expect all our hosts and attendees to respect one another, to acknowledge the feelings, experiences and identities of those around us, to create non-judgmental, caring spaces for people to be authentic, to support one another, and inclusion by ensuring that we actively create inclusive spaces for seldom heard people within the community to be heard and to be seen. Now, before I pass over to Amy, I'll give a brief background of the Deep Dive programme, which was established by the Council's Health and Wellbeing Board as a rolling programme of deep dive reports or in-depth needs assessments to research health and wellbeing inequalities and establish policy recommendations for action. There are currently 5 deep dives in our portfolio, which are either published or close to publication. The 2 published deep dives focus on end of life in Birmingham and the health and wellbeing of veterans, and both are available on the Council's website. I think Amy's going to put a link in the chat. And the learning disabilities and dual diagnosis. Dual diagnosis is the co-occurrence of substance use and mental health problems. And those 2 deep dives are in the closing stages of production, and draft versions are currently available for consultation. And we're currently developing a deep dive into mobility impairments as well. Each of our deep dive topics have been chosen carefully due to the inequalities endured by people within those demographics and the need to shine a light in those areas and create action for change. Therefore, each deep dive is a thorough, in-depth investigation into the available evidence in relation to strategies, data, epidemiology, services and lived experience. And we work with stakeholders from across the city to develop recommendations for action and the ownership of them. The lived experience element of our research allows us to capture seldom heard voices of citizens who endure inequalities. This allows us to engage with minority demographics such as ethnic minorities, migrants, citizens who have endured homelessness, and LGBTQ+ communities. And the lived experience research also allows us to engage with carers and parents, as well as service and healthcare professionals for their valuable insights as well. Now, we'll present the findings from our 5 deep dives in relation to citizens in Birmingham who identify as LGBTQ+. So if technical issues are out of the way, I'll pass over to Amy now for this next section.
Yes, technical issues. I just throw it out of the way. Sorry about that. So firstly, we're going to talk about the Veterans Deep Dive. So next slide, please. So just a bit of background to our Veterans Deep Dive. So a veteran is defined as someone who has served in the armed forces for at least 1 day, and that includes the reserves. And being a veteran is different to other occupations. So service personnel experience a unique set of factors because of their time in service. And these factors not only affect them, but also their families as well. So some of the risk factors they include are increased risk of injury and death, but also lifestyle factors such as frequent moves and the disruption that this may bring to both their lives and their families. And veterans are an important population to explore as one of the council's equality objectives to understand Birmingham's diverse communities and embed that understanding in how we shape policy and practice across the council. And our Veterans Deep Dive contributes to this by improving the collection of quantitative and qualitative data and working with citizens and partner organisations. Next slide, please. So for the Veterans Deep Dive, we commissioned 2 organisations, Age Concern Birmingham and Enigma Consulting, to run targeted focus groups. And these focus groups covered a number of themes, including what is a veteran, community and relationships, employment, education and skills, finance and debt, health and wellbeing, and housing. So the speech bubbles here show some of the responses we got to these focus groups. So I will read some of them now. So under the theme of what is a veteran, there was a comment made that veterans come in all shapes and sizes. When talking about finance and debt, one person said the main issues for ex-service personnel were to settle in the civil setup, find a suitable job, a suitable accommodation, and to control your expenditure to keep within your limited income. And then talking about housing, it was said that there are a substantial amount of ex-forces on the street. I have witnessed myself 9 times out of 10, this is due to dealing with PTSD and not having the correct access to help. So as well as these responses, the focus groups also highlighted the importance of representation. And this is not something that just applies to the general veteran population, but also the intersected communities within this population, such as the LGBTQ+ veteran community, whom experience the intersecting inequalities of belonging to both the veteran community and LGBTQ+ community. Next slide, please. So the deep dive identified that within the literature, the following inequalities are reported to be experienced by LGBTQ service personnel and veterans. So compared to non-LGBTQ military personnel and veterans, LGBTQ veterans have poorer overall physical health. They also have poorer mental health and well-being, and they report more stigma and barriers to accessing mental health support, which then in turn reduces the uptake of these services. They experience more sexual trauma, and another key finding was the substantial gap in the evidence of health and well-being of LGBTQ veterans versus the general veteran population. So, for example, there's no data on the proportion of the veteran population that take part in the LGBTQ+ community, that are part of the LGBTQ+ community. And even if there were to be statistics surrounding this, it's likely that they wouldn't be accurate, because up until 2000, service personnel could be discharged from the armed forces if they were found to be LGBTQ. And this culture of stigma and discrimination towards this community likely wasn't completely eradicated as soon as this ban was lifted. So as a result, very little is known about this population. Next slide, please. So the second deep dive we're going to talk about is our end of life deep dive. Next slide. So some background to begin. So death is something that affects us all, and this report explored the data and evidence around what is causing death at different stages of the life course and in different communities. And this deep dive supports the council's long-term ambition to have a city where all citizens are able to die with dignity, receiving compassionate and high-quality end-of-life care, and also that individuals are able to talk openly about death and dying with those that are close to them. Next slide, please. So for our end of life deep dive, several organisations were commissioned to run targeted focus groups. 6 groups were chosen. So they were the working age adults with physical disabilities, residents of the Heartlands ward, because this ward was found to have the lowest life expectancy, people with long-term conditions, the LGBT community, young people aged 18 to 25, and the homeless population. So the speech bubbles show some of the responses we got from this focus group, and I will read those to you now. So someone said, "It is sad that Dad spent his last few days in the wrong place, being distressed and uncomfortable. I'm left feeling guilty, wondering whether I should have done more." Another person said, "If someone else knows what my future could hold and I don't, they're in control, not me." And a further person said, "If there are choices to be made, I want to make them." So like with the Veterans Deep Dive, the focus groups also highlighted the importance of representation. But in addition to this, they also really emphasise the importance of having that choice and control. Next slide, please. So looking at some of the inequalities, so the focus groups identified the following inequalities to be experienced by the LGBT community. So firstly, that there's a lack of LGBT sensitivity with funeral directors, hospitals, hospices, and other services that need to be addressed through better education of these service providers. So, and a specific example of this was we heard about in one of the focus groups, there was a hospice that engaged with same-sex partners differently than they did with partners of the opposite sex. So when the partners of the opposite sex, they engaged with them more than when it was a same-sex partner. They decided to engage more with the family instead of the partner, who was probably more so affected than the family. So treating those groups differently. And additionally, that there was no specific community engagement initiatives in Birmingham at the time of this deep dive to engage the LGBT community when discussing end-of-life care. Next slide, please. So some of the recommendations that came out of our end-of-life deep dive that are specific to the LGBT community. So it's recommended there should be provision of extra community support for LGBT citizens and building in specialist processes and sensitivities to our end-of-life services on factors that could impact an LGBT citizen's ability and willingness to plan for death. So this includes concern over the complexity of more traditional faith and cultural backgrounds that could lead to an individual being ostracized from their family or community with no support, or that the life that they led might be denied or in some way covered up at the end of their life. And then also recommended that access to services at end of life must be sensitive to cultural differences of the individual and their family, as well as the complex impact of bereavement on those left behind. Also, that there needs to be further information and assistance for the public around planning for end of life, including services and procedures, and then more consideration to groups that are less engaged in palliative care services, of which the LGBT community was one. And then I will pass over to Tarira.
So I will be going through the learning disabilities deep dive and our findings. So an important thing to note is this deep dive report focuses on learning disabilities in Birmingham, but not learning difficulties. The definitions learning disability and learning difficulty can often be confused by the general public. However, they are not interchangeable, with the difference being learning disability affects general intellect, whereas learning difficulty does not. And evidence has shown that there's an unmet need for improved services. And this unmet need has resulted in citizens living with learning disabilities experiencing poorer health and having lower life expectancy. So in the Birmingham Joint Health and Wellbeing Strategy for 2022 to 2030, the Birmingham Health and Wellbeing Board recognized the significant health inequalities that affect citizens that are living with learning disabilities, and it committed to closing the gap, meaning that citizens with learning disabilities should face no disadvantage compared to any other citizens within the city. So in terms of data, so a caveat to point out here, we refer in this deep dive, the acronym LGBT was used so as to be uniform with the sources where we're getting the data from. That's why we refer in this deep dive when I'm discussing, I refer to LGBT instead of LGBTQ+. So according to the 2020 to 21 data from the Quality Outcomes Framework, there are approximately 1.1 million people living with learning disabilities in England. However, the Learning Disability Quality Outcomes Framework register only included patients that were age 14 and above, and only includes those who are known to the GP as being diagnosed. And in terms of Birmingham, in January 2023, the total number of patients, and this is patients of all ages with learning disabilities registered to Birmingham GP practice, was 10,389. And this number was taken from the data that were provided by Birmingham and Solihull ICB. However, it is important to note that this is likely to be an underestimate, and we suspect that the true figure is about triple that current figure that we have. So it is important to note that there's an absence of data collected on people with learning disability who identify as LGBT and locally, and we do not have the data around the numbers of people living with learning disabilities who identify as LGBT. However, in 2021, Out and About in Birmingham, a report that mapped LGBT lives in Birmingham estimated that 10% of the respondents had a disability of some description. However, the survey did not distinguish between the types of disability involved. In terms of lived experience, focus groups were commissioned, and these involved citizens with learning disability, their carers, and healthcare professionals. So in the going through the speech bubbles, we have one where a citizen is talking about the experience of not being involved in knowing where their mother, who was their carer, was being placed when they were ill. So I'll read out the speech bubble where he's referring to his mother. I see her about once a month, and when my carer books it for me. He books it and drives me there and supports me. The dementia has taken hold of her and is upsetting for me to see her. I'm quite worried about her, and I would like to go at weekends to see her. That would be better. My carer books it, and I don't know why I can't go more often. So his mother was his previous carer and was taken into care, and so did he, but he was taken to the opposite side of the city. And initially he would be able to see his mother, and then visits suddenly stopped and he couldn't understand why. And this was something that highlighted the importance of keeping families together geographically and ensuring that visits and communications carry on in instances such as this. Another insight that we got from citizens with learning disabilities was the insights on employment. So we had one state that there are no enterprises running anymore and there's very little opportunity. So this was taken from one of the focus groups that were held in Hockley Day Centre. And this was a male citizen with learning disabilities, and he was sharing his frustration that online courses that were available prior to COVID were no longer available. And whilst this was unlikely to be the cause for the notably low employment rates within the population, it highlighted a barrier that also affects others. And it also highlights the enduring effects of COVID experienced by individuals with learning disabilities. So another insight that we got was from day center staff, where they noted that some of the key factors that individuals with learning disabilities that face are public ignorance and lack of public education. And it's important to note that for those individuals who are at the intersection of having learning disabilities and identify as LGBTQ plus, these experiences may be heightened and they might experience additional ignorance. However, it's also important to note that it's not all the public that are ignorant and lack education, but these are the experiences that they might face. So some of the inequalities that we found were to do with individuals with learning disabilities explaining their sexuality. So relationships with partners are an important part of life, and having a disability should not restrict individuals from being in a fulfilled relationship, as this tends to have a positive impact on their health and well-being. However, some individuals with a learning disability may find it difficult to explain their sexuality and may not receive the support needed from professionals and family, with some having to conceal their sexuality to avoid learned expected negativity. We also found that people with learning disabilities face unique barriers in their personal and sexual relationships, including inadequate sex education, which is not made accessible to those with learning disabilities. And this poor knowledge of sex education can lead to them engaging in unsafe sexual practices. And we found that young people with intellectual disabilities were more likely to commonly have unsafe sex. Another inequality experienced is diagnostic overshadowing, which occurs when a healthcare professional assumes that signs or symptoms that a person may display are due to the person's learning disability or condition without actually exploring any other factors, such as biological determinants. And it's been observed that symptoms of physical ill health can often be mistakenly attributed to either mental or behavioral problems, or as being inherent to that person's disability. And this has the potential to leave other coexisting conditions being undiagnosed. An example being that despite the high prevalence of mental health problems in people with learning disabilities, they continue to be under-recognized and subsequently remain largely untreated. So some of the recommendations from the deep dive include one around data. So these data limitations limit the knowledge of where need may be, and with data showing that individuals with learning disabilities are less likely to access healthcare services that they're entitled to. So, and another recommendation was around, so as mentioned earlier, as we do not have the data that we need, we have recommended that further research is required to access local statistics and to understand what the way in which sexuality for people with learning disabilities and or autism is addressed in Birmingham. Another recommendation is around services, where services should have the flexibility to tailor their services to meet the needs of people with learning disabilities, and patient-focused care should also recognize the unique needs of citizens, such as those identifying as LGBTQ+. And the final one is around co-production and including experts by experience. So it is important that we should include experts by experience in co-producing services, and for LGBTQ, particularly for those who identify as LGBTQ+, identifying that these citizens who are at the intersection of being LGBTQ+ and living with learning disabilities will help us understand their experiences and needs of living within that intersection, and in turn resulting in co-produced services that offer that patient-focused care. And the next deep dive that I'll be talking about is the dual diagnosis deep dive. So dual diagnosis is the co-occurrence of substance use and mental health disorder. And research shows that individuals with a substance use disorder are at an increased risk of comorbid mental health problems and vice versa. So as we can see on the right, there are several factors that can lead to both substance use and mental health disorder. And it is widely recognized that substance use and mental health disorders have a neurological basis and are genetically influenced. So one of the other factors is also higher levels of stress, which have been shown to impact on brain activities in ways that can lead to decreased behavioral control and increased impulsivity. And this in turn can make individuals more likely to start misusing drugs and have less self-control over stopping misuse. Another factor is that mental health disorders themselves and substance use misuse can also impair a person's ability to deal with said stress. So for the dual diagnosis deep dive, local groups helped carry out the focus groups for us, and the focus groups they were targeted, and one of the groups that were targeted was the LGBTQ+ community, and the interviews were semi-structured. And we had a lot more, due to the local community groups that helped us to carry out the focus groups, we had a lot more engagement than in previous deep dives, so we had a lot more information in our lived experience section. So with this, you'll find that we have a few more quotes than we had in our previous deep dives. So one of the issues that was brought up was how respondents found it challenging not to partake in drinking and drug use as a member of the LGBTQ+ community, with one stating there's a lot of alcohol flowing around within the community and a lot of drugs. It seems like when people meet to socialize, it's either the weekend or midweek, it's focused on alcohol. And then we also had several respondents describe that they had given up on hope of employment due to the mental health and substance use problems, with one sharing that I have lost my job and everything because of this, and now can't apply for jobs because as soon as they hear mental health, they think you're crazy, no point applying. Another citizen shared how, due to not having anyone to talk to or support when they were coming to terms with their sexuality, they turned to alcohol at a young age. So at 14 to 15, I was hit with the realization that I was attracted to the same sex. I had nowhere to go and nobody to speak to about it. I started drinking at home when I was around that age. We also had one respondent who expressed frustration at being labelled and pigeonholed by mental health services, sharing that as soon as you get labelled, you're squashed into a pigeonhole. People started labelling me from get-go, and I only started to get help I needed after 15 years. That's a long time to be labelled incorrectly and have to struggle against it. And within the lived experience research, we also found that there is also a hesitance on the part of some of the respondents to let on too much about their mental health condition or addiction when in hospital, because there's a fear of being sectioned. And one respondent shared that I convinced them there was nothing wrong with me, and I avoided them doing what they wanted to do, which was to section me. And we also found that several respondents reported feeling sad and isolated as the result of their mental health and substance use, sharing that they, with one sharing, I felt out of place with the world. So some of the inequalities that we found was that additional stress and stigma as individuals with dual diagnosis who identify as LGBTQ+, may experience this additional stress and stigma as they face society's prejudice towards them. And this social rejection, judgment, victimization, and isolation that is often felt within the community may be implicated in the pathogenesis of dual diagnosis. And given that they experience these stresses and barriers, it's not surprising that the sexual minority populations have a higher prevalence of substance use and mental health disorders compared to their heterosexual counterparts. And these stresses might also be attributed to driving reliance on substance use to cope psychologically. And this includes stresses such as discrimination, gender dysphoria, and internalized transphobia. Another inequality is the complex sociocultural decisions and actions that may lead to drug and alcohol abuse in the LGBTQ+ community. And we also recognize that these complex sociocultural decisions and actions need to be further investigated as they're unique to the community. So some of the recommendations include, we have a data recommendation, as that is always something that we want more of. So there's a lack of sufficient data, epidemiological data on drug and alcohol abuse in sexual minorities. And this presents a major barrier when establishing health policy and prioritizing interventions. And whilst the evidence base is growing in this field, the experience of transgender people have been excluded entirely or grouped or tend to be grouped with those of sexual minority groups. And then one of the recommendations is around services. So integrated services, which are person-centered and able to cater for specific needs of certain groups, such as those who identify as LGBTQ+, are essential to working to reduce health inequalities and understanding the barriers within the community. And this will also prevent those who are LGBTQ+, and whilst also living with dual diagnosis or who are drug users, from accessing treatment that is critical in providing tailored and effective interventions. I will pass over to Amy now.
Thank you. So the final deep dive that we're going to talk about is our mobility impairment deep dive. So this is one of our ongoing pieces of work. Next slide, please. Let me just catch up. So just some background to our deep dive on mobility impairment. So it acknowledges that there is varying terminology surrounding mobility impairment, and that this term can encompass a wide range of conditions. So in our deep dive, we define mobility impairment as either an injury, illness, or congenital condition that causes or is likely to cause a loss or difference of physiological or psychological function. So the Birmingham Joint Health and Wellbeing Strategy recognises that citizens with disabilities endure significant health inequalities and is committed to closing this gap. And this deep dive helps to contribute to this commitment. So citizens living with mobility impairment endure significant health and wellbeing inequalities throughout their lives, and they typically die at a younger age than the general population. And this could be due to their mobility impairment directly impacting their ability, their interactions and their access to healthcare services. So that's what we looked into. Next slide, please. So here we've got some prevalence data. So this is taken from the 2018 National LGBT Survey, and it gives some indication of the prevalence of disability in the UK. So it's important to note kind of from the get-go that these breakdowns, there were no breakdowns by the type of disability. So these figures here capture all kinds of disabilities, not just those that impair mobility. So this isn't accurately showing what the prevalence of mobility impairment is, it's disabilities as a whole, and things like mental health conditions are likely to account for a large proportion of these figures. But anyway, looking at disabilities, of the 108,100 respondents to the survey, 16.8% answered yes to having a disability. The survey also provided a breakdown of responses from cisgender and trans respondents. So the prevalence of disability was 14.1% and 32.5% respectively. So this is kind of showing that the prevalence of disability was nearly double for trans respondents compared to cisgender respondents. And then looking at the breakdowns for intersex and non-intersex respondents, the prevalence of disability was nearly double for intersex respondents at 31.3% compared to non-intersex respondents at 16.6%. So as I previously mentioned, that these figures include all disabilities. So we can't take away from this data, for example, that there's double the prevalence of mobility impairment in trans respondents compared to cisgender respondents. And this really highlights the need for more data, and that we need this to get that understanding of the prevalence of mobility in population, because at the moment, this is what we're working with, and it doesn't really provide us with that much information. Next slide, please. So some of the inequalities that we've identified through looking through the literature. So, for example, in the 2018 Stonewall LGBT in Britain Health Report, it gave some insight into the poor experiences of disabled LGBT citizens and their interactions with healthcare professionals. So in this report, 20% of respondents had reported unequal treatment from a healthcare professional, 34% had reported inappropriate curiosity from a healthcare professional, 33% had encountered a healthcare professional that lacked understanding of their specific needs as an LGBTQ+ individual. There was also a study that looked at LGBTQI+ citizens' experience of adult social care in England. So that was looking at personal assistants and support workers. And 90% of respondents reported their needs as an LGBTQI+ individual were either not considered or only considered when their needs were reviewed, and often treated as a tick box exercise. So nationally, it's also reported that disabled LGBTQ citizens face discrimination when accessing services. So in the Stonewall survey that I previously mentioned, 20% of respondents have reported they'd actually avoided seeking a medical attention over fears of discrimination. 16% had faced discrimination when taking part in sport or exercise in the past year. And then the study looking at adult social care had reported that a third of individuals had faced discrimination from adult social care staff at their local authority, and roughly a third had faced it from their personal assistant or support worker. So as this deep dive is ongoing, we're not yet up to the stage of making those recommendations, so we haven't got that for this one. And I will pass back to Luke for a bit of a summary.
Thank you, Amy and Torero. It's quite a tall order to sum up 5 deep dives in half an hour. I think you'll all agree they've done a smashing job. So this morning we've heard about the Birmingham Deep Dive programme and how we aim to shine a light on the inequalities that citizens from specific demographics that make up our diverse city endure. So, for example, just reversing it a little bit, Amy talks about the veterans. That's a population of 1.4%, which is probably an underestimate. 1.4% of our population are from the veteran population, therefore. Our citizens with learning disabilities, we estimate 1%, but this is probably nearer 2 or 3%. And our citizens enduring substance use and mental health problems, 1.8% estimated need. Again, we think it's possibly even higher. And those experiencing end of life, which is sadly everyone at some point in our lives. So it's good to be here in LGBTQ+ History Month to underline how important it is to make our research as representative as possible by involving the voices of lived experience. And we've heard examples of how we've harnessed that lived experience and worked with stakeholders to create recommendations for action. I don't think there's any questions in the chat, but if there are any questions, I'd be happy to respond to any questions or comments from the audience. Can't see the chat. Dawn, is there anything in the chat?
There isn't any in the chat. I've been looking at it all the way through in case anything is coming, but there isn't. Bradley is asking a question. He's got his hand up. So Bradley, would you say your question, please?
Yeah, sure. So thank you for that. That was really insightful, and it's interesting to be able to have them insights into the particular communities and then from the LGBT point of view. And I suppose alongside your deep dives, you've also got the JSNAs and the community health profiles, which then all kind of give that different levels and kind of views, particularly in the LGBTQ+ space. Just a bit of a push there in case anybody hasn't looked at the rest of the portfolio online as part of Luke's team and all the wider KEG team. But just, you've mentioned a few times around the data sets and not the kind of the lack of reporting or the lack of information out there. How do you, is there any suggestions on how we could increase or improve the kind of the way that we hear from LGBTQ+ people, or how we encourage them to get involved in surveys or in sourcing this information about their experiences?
It's a really good point. Thank you, Bradley. There's a few different levels we can do that. I think if we go back to our veterans work, one of the things we advocated was a GP-friendly accreditation scheme for veterans, which has developed quite substantially within Birmingham. And one of the recommendations in there was to collect data on sexual preferences among the veterans who are using that scheme to build up a picture and I think inequalities and need and so on. So that's an example of how we can use a recommendation and a data sourcing recommendation to go in that direction. Another clear example is by involving communities with inequalities in our work with that lived experience, and that's essential when you're conducting this kind of research, to involve, as we've talked about, the lived experience of seldom heard voices, and we can look at targeted groups for that, and the LGBTQ+ community is one of those. So I think you've heard about how we involved them as a focus group for our dual diagnosis deep dive, and also did so for our end of life deep dive. Unfortunately, a lot of our work has been done over COVID with limited access to communities, but it's something we shoot for with all our work, and I'd encourage others to do the same. But I think we could possibly have better, build better links with these communities in order to access that research and to increase the likelihood of gathering lived experience as well. And would you agree with that, Bradley?
Yeah, no, I mean, that was brilliant, and definitely something that I think we do quite well in Birmingham Public Health is ensuring that we hear from particular communities that are kind of missed, or like you said, the seldom heard communities. And I think that started back when we were doing the seldom heard conversations, and now it's moved into your work with what you're doing with the deep dives and the wider work, which is incredible. And I know this is kind of just the start of your deep dive journey, isn't it? There's many deep dives yet to come. So there's lots of kind of exciting I mean, I say exciting, and we all see different things in exciting, but exciting that data sets and insights coming up over the next couple of years.
Thank you. Yes, I mean, it wouldn't be a needs assessment if we didn't grumble about access to data. But indeed, what we try and do is publish on a number of different levels. It's a 100-page deep dive document. Is not for everybody. We accept that. So there'll be an infographic that comes with it. There'll also probably be some more interactive media, maybe a slide set and an animation. But what we'll also do, if you've got a cup of tea handy and some time, is to actually publish the evidence base too. So there's, we don't like to sit on our data. We try to find an avenue to get it out there as well. So although we've got this main deep dive report, which would be about 100 pages, there'll also be a sort of 200, 300-page evidence base, which would contain all the other stuff that was also important to ensure that that gets out there as well.
Okay. Helen has put a quick question in the chat. She said, sorry, I was very late joining, but what I saw was very interesting. Will you be sharing the slides to the attendees?
This is possibly a question for Bradley, who's organising this. I think we'll actually be sharing the video. Will we be sharing the slides as well? Would there be an opportunity to?
All of the videos are going to be put into a YouTube playlist towards, hopefully, well, I mean, we should start putting the videos up soon. And then the slide decks, if the hosts are willing to share, because I mean, some people, this is their research, so they're in different stages. But if you're happy for us to share the slide decks, Luke, Amy, and Torero, then if you can send them across to me and Dawn, and we'll get them out to all the attendees.
Smashing.
All right. There isn't another question in there, but there's just a comment saying it was a really interesting talk, especially regarding veterans and the issue with the LGBT veterans being banned. Defo must, this is what's been said in the chat, Defo must affect their mental health in the long term. So there isn't any questions in the chat at all, apart from that comment.
It's certainly very interesting subject. And yeah, it's a really good comment. Do engage with us. I think, thank you all for attending. If there's no further questions, of course, thank you for attending, everybody. Very engaging questions, and I hope you found it interesting. And please get in touch with the deep dive program to engage with us in any way you see fit. If you have similar interests or particularly subjects that you think should be included in our program, I think it's this is a call to action. Really, please do get in touch. These are public documents. This is an opportunity for you all to get your fingerprints on the research and assist us and work with us. Be sure to check out the other events taking place during February for LGBTQ History Month. And I think we've got some we've got some QR codes which you can scan to reach those. And also please take the time to complete the evaluation form for today's event by scanning the QR code and by using the link in the chat. Finally, thank you for your time this morning and have a lovely day.